Hi, and welcome to the very first lecture in our endocrinology chapter discussion for this week. As always, we'll start with the word parts, combining forms, a few suffixes, and of course, abbreviations. So here we go. All right, first combining form. We've already seen this one, adeno, and it means gland. And obviously in endocrinology, we'll be discussing a lot of glandular topics. That's really all we'll be covering. Adeno plus affecto, for example, refers to the mind or a state of mind. We'll talk about affective disorders in this book. So this is pertaining to the mind. Andro means masculine. You might have an operating system on your phone called Android, which resembles man. So andro means masculine or manly. Antagonistic, this means to work against or to be opposite. So for example, if someone is antagonistic, they are working against you. Crino just means secrete. So when we talk about endocrine glands, they're pertaining to secreting within. So endo means within and crino means to secrete. Dipso, the last word in this page, means thirst. All right, let's continue. Estro refers to female or feminine. Galacto and lacto are two different combining forms that both mean milk. Gluco and glyco are two combining forms that both mean sugar. We will talk a lot about glycogen and glucose in this chapter. They both mean sugar. Gonadal means sex organs. So we are talking about both male and female sex organs. So just make a note that this refers to testes and ovaries. Hirsutu means hairy. We'll talk about hirsutism, which is excessive hairiness of the arms and the face. Sometimes women develop this hirsutism as they get older, as they age. Tropo means having an affinity for something. For example, if you have a houseplant that always turns toward the sun, you would refer to that houseplant as being heliotropic. So tropo just means having an affinity for. Tono means pressure or tone. And then virilo means another word for masculine. All right, let's continue with some suffixes. Ine, ein, is a suffix that means pertaining to. So for example, endocrine or endocrine. So endo within, crino secreting, and ine means pertaining to. So it means pertaining to, secreting within, if you write a definition from that word. The suffix ine is important because it means pertaining to, whereas the next one, in, simply means a substance. Stasis, this means a condition of being still or stable. Or at the end of the word, it just means a person or thing that produces. For example, a ventilator is a fan that produces ventilation. Rhea means a flow or discharge. For instance, rhinorrhea. So rhino meaning nose, rhea meaning flow. This just refers to a runny nose. And we say that word all the time, but it's actually a suffix that's used for a structure or a period of time. So for example, postpartum, it refers to the period of time after childbirth, but it could also be talking about structure. All right, let's talk about some system abbreviations. You'll have more than this in your book, but these are some of the most commonly used abbreviations. ACTH, adrenocorticotropic hormone. In the next chapter or lecture, we'll discuss ACTH. It's much more appealing to say ACTH than adrenocorticotropic hormone, right? And it's easier to spell than adrenocorticotropic hormone. ADH, antidiuretic hormone. DKA, diabetic ketoacidosis. We'll briefly touch on this in health and wellness. DM most commonly means diabetes mellitus. There are other types of diabetes, such as diabetes insipidus, but we're going to be focusing on diabetes mellitus in this lecture. It's what people generally mean when they have diabetes. IDDM, this means insulin-dependent diabetes mellitus, and these are individuals who need insulin injections for the rest of their lives. Then we have NIDDM, which are non-insulin dependent diabetes mellitus, and these are individuals that may still need insulin but are not required to have it, and they can use other various oral medications instead. LH, that stands for luteinizing hormone. SAD, this stands for seasonal affective disorder. This abbreviation means a state of mind where people feel sad when their pineal gland does not get enough sunlight during the winter. People in areas with long, dark winters can experience what's called seasonal affective disorder. SIADH, syndrome of inappropriate antidiuretic hormone. Again, this is another one of those long terms, so SIADH is used instead for convenience. Okay, that's it for the first lecture, the first part. We've covered combining forms, suffixes, and abbreviations. Next, we'll move on to the second part, second lecture, which will cover anatomy. So good job so far. Thank you for sticking with it, and I'll talk to you soon. All right, so hi and welcome to the second lecture in the series of endocrinology. Typically, lecture 2 covers all the anatomy and a bit of physiology. However, since this topic can be lengthy and a bit tedious for some, I happen to love endocrinology, I decided to break it up into 2 parts. So first, we'll introduce endocrine glands and their mechanisms, including feedback loops. Then in lecture 2B, which is coming right after this, we will focus on the individual glands. So I hope this approach will make the material less monotonous and more engaging for you. Okay, so first point is what are endocrine glands? It's important to note that glands can be classified in one of 2 ways because not all glands are endocrine glands. Endo means within, and the suffix CRIN, that means secrete. So endocrine glands release hormones directly into the bloodstream. So for example, the pituitary gland releases various hormones. That includes things like oxytocin, which enters the bloodstream without need for ducts. Ducts, D-U-C-T-S, ducts. All right, exocrine glands. So on the other hand, versus endocrine glands, we have these exocrine glands. They function differently. Exo means outside, and again, crine still means to secrete. But exocrine glands secrete their substances through ducts. So for example, salivary glands release saliva into the mouth. Unlike endocrine glands, these exocrine glands require ducts. Not quack quack. So to remember this, think of it this way. Exocrine glands have ducts, while endocrine glands do not. Right? That's a big anatomical difference. Everything we discuss from now on will be on endocrine glands, but I just wanted to clarify the distinction so you can avoid confusion in the future between exocrine and endocrine. All right, endocrine glands, what do? They affect the whole body in 2 main ways, either through negative or positive feedback. When we talk about negative feedback, the negative feedback loop, this is a process where the output of a system is fed back into the system to reduce fluctuations. So essentially, a substance A causes a change in another substance B, which then leads to a reduction or cessation of that original substance A. So for example, consider serum glucose control. If I eat a large number of Krispy Kreme donuts or French fries, which I love, but try to avoid due to that impact on my glucose, my serum glucose is going to rise. And this increase triggers my pancreas to release insulin, which is the B factor here, to help lower the glucose, which is that A factor. So once the glucose levels return to normal, insulin production decreases. And this process is akin to like a thermostat. So when the temperature rises above a set point, the air conditioner kicks on. And when the temperature returns to that set point, the air conditioner turns off. The next one is the glucagon and negative feedback. So this is an example of feedback. So when blood glucose levels are too low, the pancreas releases the hormone glucagon. And then glucagon turns glycogen inside the liver back to glucose. And then the glucose is then released into the bloodstream, and the blood glucose concentration in the bloodstream increases again. The interaction between insulin and glucagon creates what's called the negative feedback cycle. The pancreas is critical here. It detects that the blood glucose concentration is too high or too low. Then the pancreas releases hormones in response to insulin. if there's too much glucose and glucagon in the blood, or if there's too little glucose. And what does insulin do? It just helps glucose move into cells and converts it into glycogen, which decreases the blood glucose concentration back to that normal level. And then glucagon, that other hormone, converts glycogen back to glucose, which gets released into the bloodstream, increasing the blood glucose concentration to a normal amount. So they go back and forth. Positive feedback loop. This process is common, involves a small change in the system that results in an increase in the magnitude of the change. So essentially, you have a small effect A, which causes a large effect B, which in turn produces more of the initial effect A. A good example of this positive feedback is uterine contractions during childbirth. So the release of oxytocin from the pituitary gland stimulates contractions. These contractions create a stimulus that prompts the pituitary to release more oxytocin. This feedback loop continues. It increases the frequency and the strength of the contractions until the baby is born. This positive feedback, it's similar to like a rock slide once it starts. So more rocks continue to slide down, increasing the slide's magnitude until it stops, or a snow avalanche. So within the endocrine system, positive feedback is used less frequent as it tends to be unstable. So positive feedback systems tend to produce instability in every system. You can imagine you just have this self-feeding, cascading system that just keeps getting bigger and bigger and bigger, kind of like inflation. All right, that concludes our discussion on endocrine versus exocrine glands and the feedback loops. In lecture 2B, we're going to explore the specific primary endocrine glands in some detail. Again, great job. Thank you for hanging on there, and I will talk to you soon. All right, hi, and welcome to lecture 2B. We're going to talk about the actual endocrine glands here. So if you remember the earlier lecture, 2A, which was either just a few seconds ago or hours or days ago for you, depending on how you listen to this, it was about what makes an endocrine gland and endocrine gland and the feedback loops that we talked about. Now we're going to go through and talk about the glands themselves. So there are more glands, but these are the big ones, the important ones, and we'll go through them in a cephalocaudal order, which means from head to toe. So we'll start with the pineal gland and work our way down to the gonads, which are the reproductive organs, if you recall. All right, so the pineal gland, I tend to say pineal gland, you'll hear it pronounced pineal gland. And I'll say pineal because I've heard that more lately. So in terms of cephalocaudal order, the pineal gland, it sits atop the midbrain. And to be honest, this is one of my favorite glands. The endocrine system is one of my favorite systems. Well, I shouldn't say one. It is my favorite system. And then the pineal gland, on top of that, is probably one of my favorite glands. And I'll try to keep it to the point because I could talk about the pineal gland for a long time. I could talk about the endocrine system for a long time. So one reason that I like it, it's that its function is something that we do take for granted. I guess you could say that about every gland or every organ in your body, but it also has a lot of mystery. So it was once thought to be the seat of the soul. People actually thought you could measure the soul through here. There's actually a movie. What is the name of the actor? I can't think of the name of the actor. Where he wants to remove his soul, and of course it's like a sci-fi movie, and I think they removed the pineal gland, or the pineal gland. So in the movie, he's an actor, and he's able to do these scenes, really dark, deep scenes, because they removed his soul, and then he wants it back, and then he can't find it. He goes back to the company, they go out of business, and they want it back. I'll think about it, I'll let y'all know later on what it is. Anyway, your pineal gland works differently when you're a teenager compared to when you're an adult, and it's just interesting. It's interesting that it doesn't get a lot of attention from the medical community. It gets a lot of attention from the endocrine community, of course, internal medicine. So people talk about the pituitary and the pancreas, but the pineal gland, it kind of gets lost. It produces melatonin. I'm sure you know what that is. That gets produced through a pathway where your eyes sense the amount of sunlight, and melatonin levels will surge when the sun goes down, and it's what makes you sleepy. You might notice you can buy over-the-counter melatonin to treat jet lag and insomnia. And if you allow yourself to go to sleep when you're sleepy rather than when you're exhausted from staying up until midnight or 2 a.m. studying for this class, doing schoolwork, your body will naturally produce a burst of melatonin when the sun goes down, so that makes you sleepy. That's part of what they call the diurnal patterns, diurnal meaning daily. So when left to your body's physiological processes, you go to sleep when it gets dark and wake up when it gets light, thanks to this hormone melatonin. And that's one of the reasons that the pineal gland is pretty special. I could talk about sleep, which is also fascinating, but that's outside the scope of what we're covering now. Take one of my psychology courses and we'll talk about sleep. All right, the pituitary gland has the word pit in it. That means nothing or has nothing to do with the lecture. Just thought I'd throw that out there. So what do we have? The pituitary gland. Again, for an A&P class, you'll need to remember this as the master gland, sort of like the kingpin of the endocrine glands. We break the pituitary into two sections, the anterior and the posterior portion. I'll go through these hormones with you. Don't stress too much. Remember, this isn't anatomy and physiology. It's just to help you remember the terms and their context. So in the anterior portion of the gland, the hormones include TSH, which is thyroid stimulating hormone, and this stimulates the thyroid gland. So we'll talk about the thyroid in a minute. We have FSH, which is follicle stimulating hormone, and this is necessary for ovulation in women. We have MSH, which is melanocyte stimulating hormone, and that affects melanocytes, which give us pigmentation. This hormone is most active during pregnancy. Which is why they say women tend to glow when they're pregnant, because of this hormone. We have GH, which is growth hormone. This is necessary for growth, turning you from like a 23-inch small baby into a 6'2" adult. I didn't quite make it up to 6'2". Didn't even make it up to 6 foot. All right, adrenocorticotropic hormone, ACTH. This stimulates the adrenal cortex. So note that the ACTH is an acronym for ease of connection with your textbook diagrams. We mentioned that at the beginning of this entire lecture on endocrinology. These acronyms are not commonly used in everyday practice, but you'll see them written down. PRL, prolactin, that's necessary for milk production and lactation following pregnancy. Luteinizing hormone, abbreviated LH. This is also important for ovulation. Hopefully you enjoyed a review of these hormones from the anterior pituitary gland. Moving to the posterior pituitary gland, we have oxytocin, and this is necessary for strong uterine contractions. It's sometimes referred to as the trust hormone or the love hormone. It's elevated when you fall in love. It gives you this warm, trusting feeling towards others. Yeah, so you release that when you make connections with people. Antidiuretic hormone, ADH, this helps retain fluids and it maintains circulating blood volume. ADH is it's released in a diurnal pattern, and it's similar to melatonin. And that's it for the posterior pituitary. I'm not asking you to memorize too much. All right, the thyroid gland. Thyroid gland is located in your neck right below the Adam's apple. If you had a physical exam, you might have had the physician feel along your neck and ask you to swallow to assess your thyroid gland. The thyroid produces three important hormones, T3, T4, and calcitonin. T3, which is triiodothyronine, and T4, which is thyroxine. These hormones influence metabolic rate. So the difference between T3 and T4 is that iodine. It's not particularly important detail for the focus of this class, but just to know that it is a distinction. It's also the reason we have iodized salt. When people are not getting enough iodine in their diet, they enhance salt with iodide. Calcitonin, this decreases serum calcium. It's a hormone that decreases serum calcium. Helps you maintain a healthy level of calcium in the blood. You can have excess of calcium, and that can affect your muscle contractility and heart function. So calcitonin helps keep calcium levels from getting too high. I'm pretty sure you knew by reading it that it had something to do with calcium. Parathyroid glands. The parathyroid glands are located on the posterior surface of the thyroid in a small area behind it. They release parathyroid hormone, or PTH, and PTH is what's used to increase serum calcium levels. It works antagonistically with calcitonin, which we just mentioned, to maintain that normal calcium level. Calcitonin prevents calcium from getting too high, while PTH prevents it from getting too low. Adrenal glands. I pronounce it like this on purpose to stress that they sit on top of the renal organs, right? The renal refers to your kidneys. So people say adrenal or adrenal. I'll just say adrenal just to kind of stress that. So adrenal glands, you have two adrenal glands, one above each kidney or above each renal organ. And each gland has an outer cortex and an inner cortex, or sorry, an inner medulla. So the hormones from the cortex are aldosterone and cortisol and androgen. All right. Aldosterone is necessary for fluid balance, and it plays a role in blood pressure regulation. Cortisol, this breaks down glycogen stored in the liver, helping to maintain normal serum glucose levels. And androgens, these are male sex hormones present in both men and women. But in women, these are converted to what are called estrogens. Now, within the medulla, we have some things you might be more familiar with: epinephrine and norepinephrine. Epinephrine, that's related to the fight or flight response. This increases your focus and your awareness. As where norepinephrine, it restores normal function after the flight or fight response. Okay, just big concepts here. Not too much detail. Not too much detail. The pancreas. The pancreas, this is located posterior to the stomach, and it produces three hormones. It produces glucagon, insulin, and somatostatin. Glucagon, we sort of already mentioned, it pulls glycogen out of the liver and releases glucose into the bloodstream. It increases the serum glucose levels during periods of low blood sugar. Insulin, on the other hand, transports glucose to cells for energy, and it decreases serum glucose levels by facilitating cellular uptake of glucose into the cells. Somatostatin, this inhibits other hormones like growth hormone, glucagon, and insulin, helping to balance hormone levels for homeostasis. Homeostasis just means a normal balance. All right, gonads. So in females, the ovaries primarily produce what's called estradiol, and in males, the testes produce testosterone. So we have estradiol and testosterone. Those are the primary endocrine glands we'll cover. There are more, but these are the major ones. Let's move on to the next slide. All right, I'm sorry, let's move on to the next lecture because this is over for this part. The next lecture is going to be lecture 3 for endocrinology, and we're going to cover some health and wellness. Thank you again for sticking around this long, and I will see you soon. Hi, and welcome to lecture 3 in endocrinology, the endocrine system. We're going to talk about health and wellness in this chapter, and we're going to hit the high points on the more commonly seen problems. Right, your chapter is a little more extensive than this lecture, so the first one, let's go ahead and go again in the cephalocaudal order again. And that's going to be talking about pituitary disorders, right? So pituitary disorders, we have some very general terms that we could use to describe pituitary disorders. The first one here is hypopituitarism. And remember, hyper means excessive, so hyperpituitarism doesn't specifically say which hormones are being affected. It just says it's excessive. The flip side of that coin is hypopituitarism, which is underperformance, so undersecretion of the hormones that are necessary. Again, non-specific. It's very general, very vague. I don't know which ones are being affected because because remember that pituitary has lots of hormones that it secretes. So this one we have here is a little more specific on the slide. It's a bit of a mouthful. It's called panhypopituitarism, but this is hypo, right? So it's a subcategory of hypopituitarism. We just said a second ago. So it's undersecreting, and pan is a real clue. It is more specific than just plain old hypopituitarism, because pan, if you remember, means all, or pan scan, if that helps you, like you're scanning across a lot of stuff. So panhypopituitarism tells me that all the hormones in the pituitary are being undersecreted. And when I say it's more specific, I mean the diagnosis is more specific, because it is letting me know that yes, it truly is all the hormones in the pituitary. Let's talk about some specific things that can happen in the anterior pituitary. And this is where, remember, where prolactin is produced and released. And so you could have issues with prolactin production. You can have hyperprolactinemia. Remember, the suffix emia refers to a blood condition. So this is excessive levels of prolactin in the blood. It's a result of something else called galactorrhea, which means discharge or flow, and galacto is milk, which is, we're referring to breast milk, of course. So if you have too much prolactin circulating in your blood, you would have breast milk production. We have hypolactinemia. It's not on this slide. Some moms do have issues with insufficient milk production after birth, but galactorrhea is milk production outside of pregnancy. So we're dealing with outside of normal conditions. I shouldn't say normal. Outside of expected conditions, I guess. Now you can have some problems with growth hormone, and you can obviously very logically imagine what's going to happen with growth hormone imbalances, right? So not enough growth hormone results in dwarfism. Too much growth hormone results in gigantism. So either you're not tall enough or you're way too tall. Now, if you remember when we did our bones in the chapter, musculoskeletal, there is this growth plate. There's a line within the bone called the epiphyseal plate, right? So the epiphyseal ends of the bone are where growth actually occurs. After you reach a maturity at your age, you won't be able to grow any taller. But if you were to have an anterior pituitary disorder that resulted in excessive growth hormone production, excessive growth hormone at your age, it would result in acromegaly. And remember, megaly just means enlarged. Acro refers to arms and legs. So you can see in your book there is a picture of acromegaly of someone's foot. Normally we're not able to grow anymore, no matter how much you wish you were taller, but you will always be your height. I'll show you a video of a case where an individual past maturity developed a tumor and in the pituitary, and it caused a hypersecretion of growth hormone. That individual actually continued to grow. Again, I'll show it to you in class. All right, moving down to thyroid disorders. You can have hyperthyroidism. That's where the thyroid is producing probably too much T3 and T4. That's what we're really talking about, the metabolic rate when we talk about hyperthyroidism, not calcitonin. So for hyperthyroidism, you have a person who's thinner than most people, and regardless of how they eat, they can be a little fidgety, a little hyper. They have problems with insomnia because their metabolic rate is increased over whatever the average person's is. They also tend to be accident prone. not because they're uncoordinated, because they're just fidgety and they don't sit still. So they're more likely, because they move more, have more accidents. The flip side of hyper is hypothyroidism, where you don't have enough T3 and T4 that's not being produced. So this is the opposite of what happens to a hyperthyroidic person. Right? These people have excessive weight gain. They can't be accounted for from like your daily calorie intake. They have problems with fatigue, and their metabolic rate is very, very low. The next term we have here is goiter. A goiter is just a term that means an enlarged thyroid. I said you could assess someone's thyroid by asking them to swallow. You know, while you feel that sort of right below the Adam's apple, if you knew what you were feeling for, you could find a goiter, an enlarged thyroid, and that's just a physical finding. You can see it protruding. I showed you an animation picture here, or cartoonish pictures. You can look up real photos of this. There are lots of reasons you can have a goiter. You may need iodine in your diet in order to be able to produce adequate amounts of thyroid hormones. So if you're iodine depleted, this is why we have iodide added to table salt. We just need a very little amount of iodine in your diet to be able to maintain normal production of these thyroid hormones. So if for some reason you were nutritionally deficient, you could wind up with a goiter. So there are lots of reasons for that, but that is just an enlarged thyroid. All right, let's talk about what I think we've all been waiting to talk about, the diabetes mellitus. So remember I said there's also diabetes insipidus, and there's also gestational diabetes. They're talked about in the textbook as well. There's also claims about a third diabetes, diabetes type 3, which I won't go into here. It's more in a psychology textbook. Take my psychology courses and we'll talk about it. But I'm going to just talk about this diabetes mellitus for the purpose of our discussion, specifically type 1 and type 2 diabetes, because again, when people say they have diabetes, this is what they're referring to. They're referencing diabetes mellitus versus like diabetes insipidus. So type 1, you'll hear them called type 1, and type 2, the book calls them type 1.5 or 2. I just want to make this really simple for you. Type 1, there's two types, type 1 and type 2, for this particular disorder of the glucose insulin regulation. When I mentioned there is a type 3 in a psychology textbook that refers to a different system, but it does affect this system, so that's why they're referring to it as a potential diabetes type 3. But with type 1, this is referred to as IDDM, insulin-dependent diabetes mellitus. This is used to this used to be in juvenile, so it actually used to be called juvenile onset diabetes mellitus, and it was termed that because it was only found in juveniles. Not that adults couldn't get it later on in life, but it was mostly found in juveniles and nowhere else. It's not like they outgrew it, they just didn't outlive it. And so it was a death sentence for juvenile onset diabetes. So again, that's a very old school term. And it's not on this slide, but some people might still use that, and you might hear it. So you can imagine that if you're insulin dependent, this is a hereditary problem, typically happening early in life. Puberty is a common time for type 1 diabetes to rear that ugly head. It can happen anywhere from birth through early adulthood. That's typically when it becomes evident. So it's a hereditary thing. This person has done nothing other than have a genetic influence. So in this case, the beta cells, they don't make sufficient insulin. So that particular type that your book talks about requires insulin. With type 2, did I say everything about type 1? Yeah, they just don't have insulin. Maybe a tiny bit, but not very much. The pancreas doesn't make any, or it makes so little that it doesn't affect the negative feedback cycle for the sugar levels in the blood. Right, so again, they require insulin injections. There's a lot of technology out there now that helps people who are insulin dependent, where they don't have to worry about always keeping their insulin vials or their insulin needles and all that stuff that's required to manage diabetes. Now there's like this little pump that you can just put on your arm. It monitors your glucose and automatically injects the insulin. So technology has brought us a long way to manage diabetes mellitus type 1. When a while back it was a death sentence before insulin was ever created. What else? Yeah, that's it. If cells don't get glucose, they don't just die. Your body keeps trying to eat itself up because it thinks it needs more nutrition, and if you're not eating enough, it's going to get it from somewhere else. Let's talk about the 3 P's of diabetes, which I have here on the slide. The 3 P's of diabetes would apply to type 1 and type 2 diabetics, but this just sort of talks about the underlying problem that happens with either type. So this is just the hyperglycemia. So if you had hyperglycemia, your body would go back into the feedback loop. Remember my French fry analogy, or my Krispy Kreme analogy, right? My pancreas, the beta cells, they produce insulin. It causes the insulin then to be sort of delivered through the system, the cells, and they're able to take that glucose from the insulin and use it in that respect so that the serum glucose levels go down. It pulls glucose out of the serum blood into the cells. Now, if I have a lot of glucose, then the extra glucose is going to be stored back in the liver as glycogen. Now, if my pancreas can do this job, that's normal, it's great. But if my pancreas can't do this job, I'm going to have some symptoms that are going to be very strong clues for my doctor that there's something going on with my glucose metabolism, that negative feedback cycle. And the first one that I have on the slide is polyuria. So again, I ate all those French fries. I said Krispy Kreme because I like those as well, the warm ones, right, when they're just like nice. But Krispy Kreme or French fries, you guys pick. And right, let's say I am a diabetic. I'm not a diabetic, but let's just say I am for the case of this lecture. I go get my Krispy Kremes. Actually, I like Dunkin' Donuts. There's only one. I like Krispy Kreme. I like Dunkin'. I like them all. So maybe that's a sign that I'm headed that way. Not to the store, but to diabetes. Right. So I'm going to have, I eat my French fries. Let's stick to French fries, and I'm going to have this very quick elevated glucose serum, glucose level, but my pancreas doesn't produce insulin, right? So the insulin, it just floats around and around and around. The kidneys are really smart. The kidneys, they'll look around and say, hey, something's going on here. There's too much glucose in the blood. It's going to increase the blood pressure. So the kidneys are like, hey, the pressure's going up. What's going on? Too much glucose on here. Why aren't you getting rid of it? And so what happens is the kidneys say, you know what? Pancreas isn't doing its job. I need to filter out all this sugar. And so kidneys filter all the waste out of the blood. And so kidneys are like that little surveillance system that the kidneys say there's something up. Hey, professor, you have all this glucose. It doesn't actually say that. It doesn't know my name. But it says, hey, professor, if it knew my name, you have all this glucose in your blood. It's been in there for a long time. You've not been using it. Your cells aren't using it. What's going on? I'm going to go ahead and just dump this. So the kidneys start pulling off glucose and excreting it in the urine, right? So you start producing way more urine. And this creates this osmotic pressure that pulls extra fluid out of the circulating blood. And that's how you end up with polyuria, which means excessive, too much, a lot of urine. You're constantly needing to go to the bathroom. So people who are diabetic might have already heard this, right? Their urine, in cases where they have this kind of polyuria, the kidneys actually help excrete all this extra glucose. So the urine actually even has a sweet smell. So it's really pronounced polyuria. And it's not just, well, I had an extra cup of coffee and I got to go pee or whatever this morning. This is like continuous. If you've ever been in a hospital or around patients like this, they're going in some cases, every 5 minutes. So it gets really extreme there where they need to go to the emergency room. right? You wouldn't want to go on a car trip anywhere because you're going to have to go right away. The next one is polydipsia. Remember we said dipsia means thirst? So they're really thirsty, and can you wonder why? Right? Their families and friends will often look at them and say, man, you're always thirsty, you're always drinking. And then look how much you're peeing, right? That's of course a pretty big clue. You're peeing and look at how much you're drinking if you're going to the bathroom a lot. Sometimes it's hard to decipher what's going on, but because kidneys are excreting this glucose and pulling that extra fluid out with it, it's going to present itself. And the last word I want to talk about in this slide is polyphagia, sometimes called hyperphagia. This is a feeling of extreme insatiable hunger. It's a common sign of diabetes, but it can have other medical causes such as hyperthyroidism and atypical depression. Hyperthyroidism, remember, your metabolic rate is high and your body's burning calories and you're running through them. So you're like somebody who spends a lot of money. You go broke and you need more money. Same thing with this system. Hyperthyroidism, you're burning a lot of calories and you need more nutrition. And this can be due to either low insulin levels or insulin resistance because your body can't convert the glucose to energy, and you'll begin to feel very hungry. This is what the diabetics feel. They may have actually just eaten, but because they can't get that nutrition to the cells are saying, hey, we're waiting for our nutrition, we need those parts, you're not bringing them, and it sends a signal, it calls. It's like, hey, we need some more food, start eating some more. So you just keep eating and eating because your delivery drivers aren't dropping off the sugar, right? So that's the hunger that's associated with polyphagia, and it doesn't go away after consuming food. There's probably an Amazon package stealing analogy I could make up there. I'll figure that out for later. Where you're not getting your packages, and so you're making a call, and in some cases, it's just floating around out there. All right. So what can happen long term? You can have a condition where the body has trouble controlling blood sugar and using it for energy. With type 2 diabetes, the pancreas just doesn't make enough insulin, unlike type 1, which doesn't make any, right? And again, insulin is that hormone that lets sugar into the cells to fuel the muscles and other tissues. So with this disease, type 2, cells also they respond poorly to insulin and they take in less sugar. So it's not clear exactly what causes type 2 diabetes, but risk factors include being overweight and not very active. A good way of thinking about it is a key and a lock. So the key is the insulin, which opens the lock for the door, which lets things go inside the cell. Some cases the key could be the problem. In some cases the lock itself could be a problem. So you put your key in there, which is perfectly fine, but the lock is not responding, and so you're not opening that door. So you have all this glucose floating around. Right? But when you have type 2 diabetes, it sneaks up on you. It starts off kind of slow, and it'll slowly include things like getting increasingly thirsty, peeing way more often, and then weight loss that happens without you even trying. So, all right, that's it for this lecture. What we have next is lecture 4, which is procedures. Again, thank you very much for making it this far, and see you in the next part. Hi, and welcome to the last lecture. This is part 4 in endocrinology. We're going to talk about procedures, surgical procedures, not a lot of medical procedures in this chapter, and we'll talk about testing and diagnosis. All right, so in terms of surgical procedures, we have here fine needle biopsies. These are commonly done, and they're frequently preferred method to sample tissue or for diagnostic purposes. So think about it this way: if you had a gland and some tissue from that gland was necessary to diagnose a problem, you would probably prefer the use of a needle to obtain some of the tissue versus going through a large surgical incision, opening up that area and having access to the gland. So if it's possible, fine needle biopsy is commonly preferred because it's less risky, it's less invasive, And you can biopsy many different tissues in this organ. And what you see there is a transducer, it's an ultrasound transducer. So they use an ultrasound to actually guide the needle to the appropriate gland. All right, adrenalectomy. Remember, ectomies are used to refer to surgically removing the adrenal glands in this case. And adrenalectomy is a surgical procedure that removes one or both adrenal glands. It's usually performed to remove tumors that are large or that are producing too many hormones. Other reasons for an adrenalectomy, they include metastasis to the adrenal gland, in other words, cancer in the adrenal gland. And then we do ectomies, right? So ectomies on pretty much everything in this organ. So parathyroidectomy, thyroidectomy, thymectomy. Anytime we remove these organs, we aren't talking about medications in this lecture, but anytime these are removed because of a disease, you want to go ahead and synthetically replace the hormones that are being lost. So for example, if you had a thyroidectomy, you would take a drug called Synthroid, and that replaces T3 and T4 that get lost when the thyroid's removed. All right, and then there's radioactive seed implants. This really should be sort of under the thyroidectomy section. The thyroid gland is very sensitive to ionizing radiation. So for people who have thyroid cancer, for example, you could use radioactive seed implants to basically kill off the affected thyroid tissue. And this would be an option as opposed to a thyroidectomy. There's various factors that go into determining whether a patient should have a thyroidectomy or radioactive treatment. The seeds, they're implanted, they stay for 24 to 48 hours in the patient, and during this time, the patient is actually radioactive. So visitors, nursing care, they're all restricted. There's restrictions because the patient is radioactive. And they're radioactive for a period of time depending on the half-life after the implants are removed. Other things that you'll notice, at least from a clinical engineering perspective, is that they use a lot of disposables on these types of patients. In other words, disposable blood pressure cuffs, the ones that look almost like paper. Everything is disposable because it doesn't get thrown away in the regular trash. It actually gets thrown away in a bag marked radioactive. The interesting thing, depending on the type of radioactive element, especially for the thyroid, there is an iodine radioactive isotope that they use, and it's about 2 weeks for the half-life. I know this because I had to have a protocol for disposing of radioactive material from patients who had undergone these types of procedures. So after the implants are removed, you got about 2 weeks before the half-life gets down safe enough so it can get thrown in the trash. And so you have to keep documentation for that. And then literally you can just throw it in the regular trash. But you also need a place in your facility to store it that's shielded and away from everybody. And if you don't, you pay somebody to remove it. I know a guy. Diagnostic procedures. I told you there's really no medical procedures here. We're going to either manipulate glands surgically, we can diagnose things using the blood. That's a nice thing because the endocrine system is ductless, so all the hormones are released directly into the bloodstream. You can do a lot of diagnosis procedures using the blood, and the most common for purposes of our discussion is with diabetics, looking at the serum glucose levels. We can look at fasting blood sugar, so if you just had a regular physical exam, this is very helpful. So you've had nothing to eat for 8 hours. They told me 12. I didn't eat for a while back. So you should have something of a low range in your glucose, blood glucose levels after that fasting. They look at the serum glucose levels after at least 8 hours of fasting, and they tell you like the day before or the night before. Yeah, don't eat the night before. It's like the night before. And so if your appointment is like at 9 or 10 in the morning and people aren't eating, let's say they stop eating at 7, that's already more than 8 hours. So yeah. but it's 8 hours. That's all they need. You can do a glucose tolerance test. It's also referred to as GTT for the acronym. We didn't have that in our slides, but the acronym, I'm giving it to you here so you don't confuse it with other things. Glucose tolerance test is the standard for determining whether someone is diabetic. So, like I said, we're fasting blood sugar that's elevated. That's a strong indicator that someone's having impaired glucose delivery and uptake, but the real test is the GTT. Someone may have even had this done before. I know I haven't because they told me how this stuff tastes, right? So if you've done, so you still have to fast. You're fasting and then you do your GTT, and they ask you to ingest this very measured amount of glucose. And supposedly it's like sickening sweet. It's like a very, very sick solution. And it doesn't taste very good, is what I've heard. But if you have a pancreas that's working correctly and you have cells that are sensitive to insulin, when you take that prescribed amount of glucose, your serum glucose should decline in a very predictable manner. So it's going to go up and it's going to go down very predictably because your body's acting normal. If you do have problems, either your body's not producing enough insulin or you're not producing enough, or your cells are desensitized to insulin, then what's going to happen is going to take a very long time for that glucose to drop to normal inside your blood. So that's the GTT test, and it's a diagnostic test. All right, now for people who are diabetic, glucose self-testing is important. It's important because knowing what their serum glucose level is when they either need to calculate how much insulin they're going to inject, or even if they're going to be able to eat or what they're going to eat. So you might have seen the commercials for these things, or you may know somebody who is constantly checking their blood glucose levels. And this again looks at the distribution of carbs to fats to proteins. Is what we're kind of looking at if we're looking at the entire picture on maintaining your health. But with the glucose self-test, we're looking at blood glucose inside the blood. Actually, it's looking for an enzyme reaction. So it's actually testing for an enzyme that exists when you have glucose in the blood. So it doesn't actually test for the glucose itself. Some of the new ones may, but so you're looking at the reaction. So you're looking at that enzyme on these particular meters you see there on the screen. So this is where you get the little tiny poker, the lancet is what it's called, and you poke your finger until you get a little, bleeding. You put a little drop of blood on these little test strips. The test strips are designed to be read by a meter, right? So there's chemicals on that test strip that are going to produce a reaction and release a certain amount of current based on whether you have a certain amount, whether you have this enzyme or not, or how much of this enzyme you have, and it's going to be converted into an approximate blood glucose level, which you'll see on the meter. And it's very close. It's good enough for management. Right? There are more accurate ways of doing this, but this way is actually very, very close. And it can be done at home. It can be done in what's called point of care, where you just do it at home. There's various assays. So we can really look at anything that's in the blood. So you could measure all the different hormones, thyroid hormones, calcitonin, and all these kinds of different things. This is very useful for diagnosing endocrinology disorders. Sometimes when patients come in and they have complaints and symptoms of things, looking at the actual hormone levels is very, very useful. And most of this is done with blood. So your book talks about an assay that's done using urine, but most of the diagnosis is done with blood. I actually appreciate the blood test, because if you ever had to get some kind of urine analysis test and you never go at the right time, and you get, you're almost done with the doctor and they say, well, now I need you to pee in a cup. And it's like, I wish you told me that before I just went. Blood, they can just suck that out of you anytime. So I like the fact that there's blood tests. And that's it. That's it for endocrinology. That was nice and easy. I think the fact that there's not a lot of medical things to do other than manipulating hormones or replacements, that's a relief. So the next thing you're going to do is any exercises, discussions, or quizzes that are assigned for this lecture. Great job in making it this far, and I will talk to you soon.